Welcome to Let's Clear the Air, a podcast sponsored by the Allergy, Asthma, and Sinus Center, dedicated to educating listeners about allergies, asthma, and immunology.
This is Marcella Feathers. Welcome to Let's Clear the Air, all things allergy, asthma, and immunology. We are here with Dr. Phil Jones in our Johnson City location. Hi, Dr. Phil.
Hi, Marcella.
How are you doing today?
I'm doing fantastic.
We
Marcella.
are so glad to have you. This is both of our first podcasts.
Yes, exciting.
It is. So we get to muddle through this together, but I'm sure it'll be great. So let's give a little background to those who are listening to you, how you got started in allergy, and where you're from, just anything that might give us some insight into you.
Marcella, I grew up here in East Tennessee, Johnson City, in fact. I bypassed Knoxville and ended up in Tuscaloosa, Alabama, where I did go to the University of Alabama. And I was in UAB in Birmingham for many, many years, and then went back to Nashville and back home. And I'm really glad to be home. And, of course, allergy, at first I thought I wanted to be a pulmonologist, and I did end up being a pulmonologist, but it was allergy that I really loved. So I did both of those, and I get to practice both of those, and they're just a fantastic specialty, and they complement each other just wonderfully.
Yeah, you practiced pulmonology specifically as well for several years, didn't you?
20.
20.
Yes.
Wow.
Yes. I've been here with our group for, I think, 21 years now, Marcella. Yes. We both had less gray at that time.
We certainly did. Both of us are completely white-headed, or white-bearded right now.
Yes. We won't comment on my hair color.
No, we won't comment on that. Well, now, what brought you back to the Tri-Cities area, the Upper East Tennessee?
Well, the Tri-Cities, as you know, Marcella, because you grew up here too, is a wonderful place, right?
Yes.
Beautiful countryside, but it's also a little bit of an underserved area too. We have a need for subspecialist primary care, and we certainly suffer with allergies here. I mean, I can't stand in a line anywhere and not hear somebody I think, boy, they really need to see us, right? They're sneezing, they're coughing, they're clearing their throat. So it was a huge need for allergists and still a huge need for more allergists. And as we speak, as I said, I've been here 21 years. More and more allergists are retiring. And even locally, we've had 2 or 3 retire and 1 to soon retire. So anyway, a beautiful area, family here, lots of need for allergy and allergists, and it's just such a wonderful place to be and a very rewarding place. People are very appreciative of the service we provide and the improvement they get from seeing an allergist.
Now, it is a beautiful area, lots of green mountains and lakes. What do you see a lot of here in the Tri-Cities?
The Tri-Cities, we see a lot of the kind of usual things, hay fever, asthma, but there are other things we see that people might not think of an allergist for. We see medication allergies, and we can do penicillin allergy testing and do what we call delabeling penicillin allergy, which is a huge service to the patients and their primary care providers. We take care of hives. And eczema, patients who suffer with eczema and hives, they can be very disabling and just make them miserable. And so allergists serve a very unique role taking care of those patients.
Well, now, a lot of people think they have penicillin allergy when in truth they may not.
Yeah, so in the old days, if you were a mom and you were taking care of your toddler or infant and they had an ear infection and the doctor put them on amoxicillin and they had a rash in a few days and you called back, they'd say, oh, never give it to them again. They're allergic. And for the rest of their life, they went, I don't know what happened. Mom told me I'm allergic and you die. I still thinking you're penicillin allergic. But the vast majority of those patients who were told they were penicillin allergic are not. And penicillin is still the best. It's the oldest, but still the best family of antibiotics. And I always tell my patients, whether you're sitting in my clinic, in an operating table, or an ICU bed, you want access to that family of medications if possible. Because penicillin allergic patients get put on alternative agents, which are not as effective and can lead to multi-drug resistant pathogens, C. diff colitis, longer hospital stays, more expensive hospital stays, delayed wound infection healing. So just many, many reasons. And it's so easy to do, too, the test. couple
I was
of
getting
hours.
ready to ask, what does that entail, testing for penicillin?
So testing first, kind of go through the history, what happened, because there are some medication reactions you absolutely can't be tested for. But the vast majority of them, if it was a rash, if it were hives, if it were my lip swelled, wheezing, we can do tests for those. And that test, some people it's a scratch test, some people, and a scratch test, of course, most people wouldn't know what that is, but that's a plastic device introducing the allergen just in the superficial layer of the skin. Some people, there's intradermal testing, depending on what their history is. But basically, we risk stratify them. Are you low risk for penicillin allergy, moderate risk, or high risk? And then and if you're low to moderate, hey, we move forward. Some people we don't even test. We just say, here's amoxicillin, you're extremely low risk. And we watch them closely. And so then they can go back to their primary, and now they say, hey, I was tested. Then they gave me the penicillin. They gave me an oral challenge in the office, and I know I'm no longer allergic.
And what a relief.
Yeah,
Then they
what a
can get
relief.
that treatment,
Yes, absolutely.
Now, do you test patients who are of all ages? Can you test for?
Yes. So all ages, we do that. I've done those in pregnancy. You can do those in the hospital if needed. I mean, those are really useful services for a variety of ages and a variety of health conditions.
Okay, very
Yeah,
good.
fantastic stuff.
Yeah, that's hopeful for folks who may just think or have assumed, like you said, my mom told me I was allergic and therefore come in and get tested for the penicillin.
Absolutely.
And it's easy enough.
Yeah. Unfortunately, I wish we had that test for all medications, but we really don't. But we do help people with other medication allergies. It's just much more challenging because there's not really a well-studied, standardized test for all those other medications.
Now, you said you spent several years in Alabama at school. How many years total?
Marcella, I'm not sure. I know I was in Tuscaloosa for 4 years and Birmingham probably 10. Because, see, I got sidetracked, Marcella. I thought I wanted to be a dentist first.
Well, I saw up there your Doctor of Dental Medicine certificate or graduation.
Some of us, we just go different paths, but we got where we needed to be, okay? So I was there for that and then ended up in medical school because I thought, well, maybe I do want to stay in dentistry. Maybe I want to do an oral surgery residency or fellowship. But once I did medicine, I realized pulmonary and allergy was right where I wanted to be. And so I stayed there and then went on to Nashville at Vanderbilt and then back home.
For those who may not be familiar, what is the difference between or the difference in the studies of pulmonology and allergy? Because, of course, allergy does have to do with your breathing. At what extent or at what point does that move into pulmonology?
There is a good deal of overlap between pulmonary and allergy, okay? So if I'm a pulmonologist taking care of lung conditions, there are a lot of things upstream, i.e. the nose and sinus, the upper airway, that can aggravate things in the chest. And asthma is one of those areas where pulmonologists and allergists overlap. We both take care, and both provide very useful, they complement each other. Sometimes I feel in training there's we do asthma better than you do asthma when it comes to pulmonary and allergy. But I've always found that the allergists do a fantastic job taking care of asthma. They love it. They breathe it. Whereas a pulmonologist, they're more hospital-based, and they take care of many more COPD patients, pulmonary fibrosis patients, bronchiectasis patients, chronic lung illnesses. And of course, that's the beauty of asthma management. They can come in very, very, very sick, very poor quality of life, always in the emergency room, flaring up on steroids, and you make a good diagnosis, a good treatment plan, and they come back and they're just, they're better. Their lung function has returned to normal. COPD patients, we love them. They're great people, but you can treat their disease, but you can't reverse their disease.
Whereas with the asthma, there is a treatment option, treatment plan.
Absolutely. And you can reverse it, and it's so rewarding. They come in and they're just like, oh, Dr. John, you saved my life. And you're thinking, no, I didn't, but I know why you feel that way.
Sure, because that would make a huge difference in their quality of life.
Yeah.
Do you see a lot of patients of various ages with asthma.
Yes. So it's interesting. My oldest patient with new onset asthma is 84-year-old.
Oh, wow.
And I love her questions. Why would I get asthma at 84?
Yeah, I wouldn't have thought that's even possible.
Right. So most people, very familiar with asthma of childhood. That's where we see it most, where most asthma evolves. But in our group, we're seeing asthma patients with new onset asthma of all ages. And another thing we see is patients who've probably had it for a long time but weren't diagnosed. So any of my patients I meet, they say, well, I get bronchitis 2 or 3 times a year. My first thought is, that's probably not bronchitis, that's probably asthma, and it's flaring up for whatever reason.
Mm-hmm. Because there are allergic triggers for asthma. That is one of the
Absolutely.
precursors, correct?
Yes. So allergies would be a very common reason for asthma to flare up. Infection would be another reason.
Like
Exercise.
Sinus infection.
Oh, yeah. Yeah. I always tell my patients, Marcella, I always point to my nose. I say, if this isn't happy, and then your chest is not going to be happy. And all of them are like, yes, it starts in my nose, and it's immediately in my chest. Okay? And I think allergies have a unique role there, right? We can test for allergies. We can treat sinus disease. And by optimizing that, if we're co-managing that asthma patient with the pulmonologist, we're helping them optimize that patient's asthma control.
What are some of the warning signs that you would say people need to be aware of and that would be signs for them to come see you?
Yeah, so I think patients who are, so we have in asthma management, we have rescue inhalers and then we have maintenance inhalers. Mm-hmm. So patients often get rescue inhalers and they don't realize, well, how much should I be using it? What's too much? What should be a red flag that I need to see somebody? So I always tell them, if you're needing your albuterol more than twice a week, or you're waking up more than 2 nights a month, scrambling through your bedside, nightstand to find your albuterol, that's somebody who does not have well-controlled asthma, okay? Mm-hmm. They need to see somebody, okay? Patients who are frequently in the emergency room, patients who are frequently on steroids. These have long-term consequences, and there are ways to manage asthma where you do not have to deal with so many frequent exacerbations or steroid burst or ER or urgent care visits. Mm-hmm. And nowadays with urgent cares and ERs, it's very easy. If I think I'm sick and I need prednisone, I go and you get it. Mm-hmm. But that's not the best way to take care of it. Your life can be a whole lot better. Your quality of life can be better.
Mm-hmm. And for the littles out there who their parents are kind of wondering, does my child have signs of asthma? Does he not? Is it just a sniffle, a cough? What advice would you give them?
Yeah, depending on the age of the child, sometimes it is challenging. Right? It's not unusual if you're 6 and under to wheeze when you get sick. But when you start getting wheezing when you run and play, or wheezing when you go visit grandma and she's got cats, then that's asthma no matter what age you are, okay? But if it's just wheezing when I get sick, we watch those people closely. Sometimes if they're frequent and severe, we manage them as asthma. But as they start to get older, that if it's just an infection-induced wheeze, that should resolve. And then I'm always monitoring, I always ask, do you wheeze around cats? Do you wheeze when you run and play? And then as they get older, we can do spirometry too, which helps us diagnose, yes, there's obstructive lung disease. And then we can test, does it reverse, either with treatment or with albuterol? So there are many ways to diagnose asthma.
And the spirometry is how you measure their air capacity, is that correct? Or their lung function?
Yeah, so it's a great way. So it's one of the pieces of the puzzle we use to optimize asthma management. And, in busy primary care practices, they don't always have time to do spirometry. Not all primary care clinics have spirometry. And I meet many patients over the years who they feel they're well controlled, or their provider felt they were well controlled. But if I do spirometry and there's, 40% lung function, 50%, 60%, those are patients who were flying under the radar. They were having ongoing inflammation, and it wasn't being addressed or treated. So spirometry is a really important piece to optimizing that asthma control.
And I'm sure once that asthma gets better controlled, they feel so much better.
Yes, that's that person that stops me and says, "You saved my life."
That's good to hear.
Yeah.
Okay, so Dr. Jones, as the seasons change, and here in Upper East Tennessee, we're getting ready for summer. The boats, I see a lot of boats out on the lake and water, but that also means we're going to be getting into a lot of stinging insects. And allergists are specialized in that area. Why don't you tell us just a little bit about how the allergist can help folks who have either maybe experienced a sting that was a little bit more scary than they thought it might be, or those who are concerned about being stung, like with a little or an infant.
So, Marcel, it's interesting. We do see a lot of bee allergy patients, or specifically bee venom allergy patients. And so when it comes to bee stings, if we get stung, we expect a local reaction, okay? So if I get stung on my finger's going to swell. Sometimes if I get stung on my fingers of my patients, it's not just their finger, it's their hand or even up their arm. But that's a local reaction, not an allergic reaction. If I get stung on my finger and I break out in hives, depending on your age, but if I wheeze or my lip swells or my throat swells or my blood pressure drops, then those are all suggestive of a bee venom allergy, okay? Now, that's a whole new local reactions are aggravating, uncomfortable, disruptive, impair our quality of life, but they're not in themselves life-threatening. But if I make IgE, now IgE is the antibody that mediates or triggers allergic reactions. If I make IgE to bee venom and I get stung, then I'm at risk. And then I can't control when I'm going to get stung. I can't live inside forever. I want to get out and do the things I enjoy. And most people here in Tennessee, we like to get outside and do things. And so historically, people avoid getting stung as best you can, which isn't very successful, and carry an EpiPen.
Well, if they know about an EpiPen, if they're even that.
Yeah, even if you're right, even if they were savvy enough to see their primary care doctor and get evaluated in at least an EpiPen. Okay, but there's so many better ways to manage bee venom allergy, or specifically bee venom anaphylaxis, especially if I'm a high-risk person. I hike 30 miles out of the town or 100 miles, and I'm out there with myself or a friend, and or my job, I'm a lineman, and I'm always into bees' nest, or I operate heavy equipment, and it sits for months, and then I fire it up, and the bees that have made nest come flying out of there. So those patients need to be aware of a thing called bee venom desensitization, or bee venom allergy shots. That can decrease your risk of an anaphylactic reaction to bees from, say, 70% down to less than 5%, okay? And even of those 5%, Marcel, it tends to be a skin limited reaction. So I hate to use the word cure, but daggone, it's pretty darn close to it, okay?
Right.
So anyone with bee venom anaphylaxis should be evaluated by an allergist. They should be evaluated for an underlying mast cell disorder, and they should be given the option of knowing about bee venom desensitization. Patients are very excited about bee venom desensitization and being able to get out and enjoy life. And they still have to carry an EpiPen. You still have to be careful. I don't want you, knocking down bees' nest. But you should be able to get out and enjoy the things you like to do, and have that quality of life that goes with that. So I love bee venom patients.
And it's correct that if you have had an anaphylactic reaction to your first bee sting, or have noticed a first anaphylactic reaction, then if you are not treated or don't have that type of immunotherapy in place, your second sting could be a lot worse. Is that correct?
When it comes to severity of reactions, Marcella, I always love my ER colleagues, respect them tremendously, but they're what they tell my patients. They see that patient, right? They had a reaction, they ended up in the emergency room, and they tell them, boy, good thing you came in, because everyone after this will be worse. But in reality, anaphylaxis, whether it's to a food or to a bee, it's highly variable between reactions. There's so many factors that go into the severity of a reaction. So there's a lot of variability. But we got to be prepared for the worst case scenario.
Of course.
So we carry that EpiPen, but ideally we do that and do bee venom desensitization. And then we can, I tell my patients, it's not a suit of armor, but you can still go out there and you're protected.
And why take an unnecessary risk, especially as you said, if you're a lineman or you hike and are 30 miles out from your car, which brings up, keep that EpiPen with you. If you have one, keep it with you.
If you're hiking, it's no good if it's at the trailhead and you're at the at the waterfall, right?
Right, or if you're on a boat and it's at the shore.
Yes, absolutely. These things happen. So I always tell patients, this is how things go wrong. You didn't have your EpiPen with you. You had it and chose not to use it, and that really happens more than it should, or you waited too long to use it.
Where the immunotherapy comes in handy too, though, because you have been maintaining a schedule with those shots and building up a resistance.
Yes, absolutely.
Explain what immunotherapy is exactly to those who may not know.
Yeah, so immunotherapy can be as complex as you want it to be, or it can be as simple as you want it to be. And there are things we know about immunotherapy, and there are things we're still learning about immunotherapy. But the beauty of immunotherapy, it's been around over 100 years, so we have a lot of experience. And over the last several decades, more and more in-depth research into what does it do? How does it get rid of my bee allergy and those kind of things? And so really, I explain it to my patients best in a nutshell. Most people, when they get stung, form IgG antibodies, which binds the venom, clears it. We don't have any symptoms. But a few of us, 30-40% of us, are prone to form IgE antibodies. And that triggers mast cell, which triggers hives, wheezing, drop in blood pressure, all those classic symptoms. And so what we're trying to do with immunotherapy is gradually increasing concentrations, retrain your immune system, not to form IgE, but to form IgG, or what we might even call IgG blocking antibodies. And there's a lot of other down-regulatory cytokines with that. And again, that's where immunotherapy gets really complex if we get into cytokines and those type things. But in a nutshell, it does retrain our immune system not to react to those things that we've built an allergy to. And that's whether we're talking about bees or pollen and those kind of things.
Now, is it a natural solution? All natural?
Yeah, that's a good point, Marcella. You know, people nowadays, they're educated about medications. They question more than ever. Well, what is this? Why do I need it? What can I expect it to do for me? And what are the long-term consequences of that? And we have more and more patients who are, exploring, it's not my area of expertise, but, naturopathic medicine and homeopathic medicines and those type things. Well, there's nothing more natural than immunotherapy. It's not a medicine. It is what you are allergic to, given to you subcutaneously in gradually increasing doses to build that immunity. So I always tell patients, you can't get more natural than that.
That's good to know.
Yeah.
That's good to know. All right, so let's talk about what your interests or hobbies are. We had discussed this a little bit before the podcast started, but let's hear what you like to do on your time off when you're free and on a pretty day like today.
When my family allows. They always come first, but when they allow, my favorite thing is I'm always looking for old things. And this began with I happened to buy an old 1942 Jeep. And then I started collecting pieces for that Jeep and then tools for that Jeep. And this led to an all-out addiction for old stuff. I'm not going to use the word junk. My wife would like to explain. That's her. Yes, what are you going to do with all this junk? They're clearly treasures. I like to tell her I acquire rare artifacts. Okay. But anyway, that led to collecting old things. And the 40s is my favorite years, the 1940s, specifically 42 to 45. And so I have signs from the 1940s, of course, the Jeep from the 40s, anything I can find, old advertising. So I spend half my days on Friday, Saturday, and Sunday digging through something, flea markets, barn, whatever I can find somebody will let me go through, trying to find those hidden treasures. And I think part of me thinks, hey, that's just a way to preserve that. Otherwise, it's going to get scrapped or junked, or it's just going to rot away. So, yes, that's my allergy is my passion. That's my second passion.
What have been some of the most exciting things you've found?
So it's amazing. You would think with World War II and all of the stuff we sent overseas that there would be none of that original stuff, tools, pieces to the old Jeeps, those kind of things. But I find those routinely, those old Jeeps. They just so mass-produced. Some of that came back. Most of it stayed overseas. But some of that is still available, so that's fun. But finding, if you're in an old barn and there's a pile of junk and you take the time to dig through it and there's that Pepsi sign in there, there's nothing better than that. Okay, that's my favorite.
Do you just see a barn on the side of the road and go up to the owner and go, hey, do you mind if I rummage through?
I would love to do that. That's a little bit out of my comfort zone kind of thing. So usually as I get to know people, then people start saying, hey, you need to talk to him. He likes that stuff. Word of mouth. And then people will be like, hey, I hear you like this. Would you like to come check out my barn? It's got a bunch of dad's stuff in it. And that's the way I do it.
Now there's isn't there like a multiple mile long?
Yeah. I have not done that, but a lot of my buddies have done that. Okay. So, hey, Marcel, what I really hope is somebody will come along. You know, Mike and Frank have done their thing. It's time for Dr. Phil to do his thing. You know, they this is a voice audition, I guess, for that. But maybe they need to come film me, and we'll see if we can get a, you know.
You mean like an HGTV special
Dr.
or something
Phil,
of the sorts?
Antique something. You know.
You might have to go by Dr. PJ or something like that. Dr. Phil's taken.
I've always thought of that, Marcel, but here's how I answer that. And I think this would work. Okay. Hi, I'm Dr. Phil Jones. See? Count to 3, Jones. And then he couldn't say anything.
Kind of like Bond, James.
The delay is important.
It is. That is key.
Yeah.
All right. Well, thank you so much for joining us today. I really enjoyed our conversation.
Marcel. I enjoyed it.
And I hope we get to hear again from you soon.
Absolutely. Thank you.
Thank you. And thank you for listening to Let's Clear the Air.
We hope you've enjoyed this episode of Let's Clear the Air. Please consider following this podcast, and remember, if you want helpful and accurate information about allergies and asthma, our allergy experts are here to clear the air.